What would you say are the biggest blind spots in modern medicine that are causing us to, not feel our best, be unwell, etc.?
Well, it's amazing. A small group of people in medicine at the top are making all the decisions, and they're issuing recommendations with kind of this centralized authority that we've never really historically had in medicine. And it's getting sort of more and more concentrated. And the thing is, if we make recommendations as doctors, I love being a doctor, I'm a doc, if we use good scientific studies, then we shine as a profession. But if we're just making recommendations, kind of winging it, using opinion, we have a terrible track record. And we develop these giant blind spots. Like today, we have the most medicated generation in human history. What are we doing? The system's broken. The docs are burnt out. People don't like it. It costs a fortune. Maybe we need to talk about treating diabetes with cooking classes instead of just throwing insulin at people. Maybe we need to talk about school lunch programs instead of just throwing Ozempic at children. We're creating a generation of patients out of America's children right now. We need to think differently, and there's a movement within medicine to talk about these issues, to talk about food as medicine and the role of general body inflammation in so many diseases, be it mental health related diseases, be it cancer, heart disease. Inflammation is kind of a common thread. But we've got these silos at the NIH and Pharma where they are either funding drugs or they're funding what the old NIH professors believe should be funded. And, they're in their 70s and 80s over there at the NIH. They probably need term limits. We need to be talking about sleep quality and what we eat and the microbiome. So there's a movement right now in medicine to say, I don't care what the NIH is going to fund me to study or pharma. I'm going to study it because I believe this is central to health. And there's a body of research that's overwhelming. It's amazing. It's coming from top doctors, top centers, top journals, but people aren't aware of it. So I wrote the book Blind Spots to kind of educate people on the latest research on the big topics in health, where modern medicine has gotten the big recommendations perfectly backwards.
Do you think most physicians are unaware of the connection between diet and lifestyle and chronic disease?
Yes, but not for bad intentions. I think we attract good people in medicine, but we've got a bad system. And it's not a system we designed, it's a system we inherited. So you get these highly creative medical students. They start off altruistic, creative, bright. I mean, they're amazing. They're inspiring. Like 90% of them want to do medical missions or charity, if not full-time, as a part of their practice when they start. And then we beat them down with this rote memorization and drug indications until they're burnt out. And they come out at the end of 7 or 8 years, different people. And it's not that they're bad, it's that we've conditioned them. But enough people now are recognizing that we've got these blind spots. We've got these big things we don't talk about, like nutrition. Heck, I think I got maybe 2 hours of it in medical school. And to be honest with you, it was misinformation, nutrition. So I'm not even sure it was good to have those 2 hours. It might have been better to have 0.
What do you mean by that?
Well, they're pushing the low-fat diet. That's the dogma of modern medicine. If you think about it, if you're not a smoker, where we're going to tell you to stop smoking, that was the number one health recommendation of modern medicine, was to eat better, defined as avoid fat. And it was an old dogma that came from this guy, Ansel Keys, who was a politician in the 60s, kind of with a PhD behind his name.
Politician first.
Yeah, he didn't run for office, but he essentially functioned as a politician. And he convinced the world that low fat prevented heart disease, even though the data didn't support it. He crushed the scientists that said, no, it's sugar, it's refined carbohydrates, and some degree of ultra-processed foods, which we didn't really understand at the time. And it's this old story of crushing dissent, and a small group of people decided what the world should do, and it became a bandwagon effect because medical dogma sort of takes on a life of its own. So people need to know what the truth is. The truth is that there were 3 gigantic studies designed to test the low-fat diet hypothesis. All 3 failed to find an association between reducing fat, and preventing heart disease. All of them. Gigantic studies, the biggest in the history of medicine. And when medicine gets it wrong, we don't come out there publicly with humility and say, we got this terribly wrong, we feel terrible, and we're sorry. You should really be focusing on this other fact. Instead, they just kind of fade out. And this arrogance really creates a lot of confusion out there. If you think about it, many of our modern day health crises may have been caused by or hastened by the hubris of the medical establishment. The low-fat diet, pushing the food industry into refined carbohydrates as obesity rates soared. Now, there were other factors, but the peanut allergy epidemic is, by and large, was ignited by the medical establishment giving the wrong information to parents 24 years ago, telling them to avoid and abstain from all peanut butter and peanut products in kids 0 through 3. Well, avoidance caused peanut allergies. It didn't prevent it as they thought.
Wow.
They should have done the study first. Saying opioids were non-addictive, igniting the opioid crisis. Denying women hormone replacement therapy, causing needless suffering. There's probably no medical intervention that beyond antibiotics that helps the health outcomes of a population more than hormone replacement therapy in perimenopausal women. So they've got so many things perfectly backwards. I share those stories in the book Blindspots, but also want to tell people about what's going on with microbiome research. It's the hottest thing right now. I think it's one of those things that relates to every aspect of health, including some of the areas that you've been interested in on your podcast.
Yeah, it's definitely a trending topic, but along with the buzz that it has coincided with, there's a lot of a lot of misunderstandings about the implications of gut microbiome research and how to, the actionable aspects of it. There's a lot of misinformation, I would say, out there.
Yeah.
Exploiting the relative nascency of microbiome research.
Yes.
What would you say about it?
The wildest thing I discovered in doing the research for the book was this study out of Mayo Clinic that looked at the role of antibiotics in messing up your microbiome. Because doctors have believed for a while that taking an antibiotic is like carpet bombing your microbiome, which the microbiome, if, your listeners may know, but is the garden of millions of different bacteria that line the gastrointestinal tract and train the immune system, produce serotonin involved in mental health. They help with digestion. They make vitamins. They are involved in estrogen regulation. There's so much, and we're just at the tip of the iceberg in understanding what's there. But they did this amazing study at Mayo Clinic. I'm amazed doctors don't even know about this study. It was published in their own little journal at Mayo. They have their own in-house journal, probably because they couldn't find a traditional journal that would take it. But they looked at kids who had taken an antibiotic early in their childhood compared to kids who did not. I mean, about 16,000 kids. And they were matched. And in the analysis, kids who took an antibiotic in childhood early on were more likely to be obese, have asthma, learning disabilities, almost a 300% increase in celiac, this whole host of chronic diseases that we kind of scratch our head around in medicine and say, I wonder what causes celiac. It's right there. The data are speaking to us. And the kicker was the more courses of antibiotics a person took in childhood, the greater the risk, what we call a dose-dependent association, which kind of suggests a cause and effect. And so antibiotics are used in agriculture to plump up animals for food, make them fatter.
That's fascinating.
And
I've heard that. I've read about that in various agricultural journals, but how does that work?
So we know the association is there. I'm not sure it's known how, but it turns out some of the bacteria in the microbiome produce GLP-1, the active ingredient in Ozempic and the other drugs. And so what's happening? Is it increasing absorption levels of food? I don't know, but this world expert on the microbiome, whom I interviewed for the book, noticed that this was happening in agriculture and wondered, is it happening in humans? And his own daughter had gotten a bunch of antibiotics just because the doctor said, oh, probably won't help you, but there's no downsides to antibiotics. How many people believe that dogma? And their daughter took a bunch of courses of antibiotics unnecessarily, pretty clear, and started struggling with these chronic diseases. And intractable, disabling, abdominal discomfort, and so he decided to commit his life. He was already chief of medicine at NYU, and he decided to pivot and commit his life to studying the microbiome. He's done this incredible research where he looked at if it makes animals more obese, does it do the same in humans? Yes, it does. He's done that definitive research. It's also a factor when a person's born by C-section that so first of all, C-sections save lives and antibiotics save lives, but they're massively overused. Okay, most antibiotics are unnecessary, according to a CDC study. Not sure that's the best source to be citing anything nowadays, but that's well known in the field. When a baby is born, when a baby is in utero, their gut is sterile. There's no bacteria in that gut. When a baby is born through a vaginal delivery, the birth canal, which has a lot of bacteria in it, will seed the microbiome of the baby. And that microbiome will be augmented by bacteria from the colostrum, the early breast milk, the skin of the mother, the kisses of all the family members. And that's how the microbiome forms by and large. But when a baby is born by C-section, a sterile baby with a sterile gut is extracted from a sterile operative field. And what may seed the baby's gut are the bacteria that normally live in the hospital, which are now good bacteria. And so we're messing with the microbiome in ways we don't appreciate. And people are told, I think we should just do a C-section because, it's more convenient, or it's getting late, or people are told inappropriately that there's no difference between a C-section and vaginal delivery. There are massive differences. And so the microbiome has been omitted from medical education, from modern medicine, from the medical journals, but it's starting now to be recognized to be central to maybe mental health, maybe involved in dementia, Alzheimer's, maybe involved in this epidemic of learning disabilities. Turns out in that Mayo Clinic study, kids who took antibiotics early in childhood had higher rates of learning disabilities. Now, when you're a scientist like myself, we do lots of research on my team at Johns Hopkins, if there's something in society that is skyrocketing, like learning disabilities and autism, and you have a signal in the data from a study that says, hey, look, microbiome, there may be some association, you've got to investigate that. And there may be something there. I mean, we have introduced a host of diseases in the modern era that never existed before the mass production of penicillin, the first antibiotic. So the 1950s and 60s really ushered in a whole host of inflammatory diseases. Maybe the pro-inflammatory bacteria in the microbiome overgrow when other things kill some of that bacteria, and may result in more body inflammation. There's an association with the microbiome now, and the colon cancer we're seeing in people in their 30s and 40s, that's going up. Inflammatory bowel disease, ulcerative colitis, IBD, celiac. I mean, we didn't even see these diseases before penicillin. So people need to know when they get a little sniffles or viral infection, or their doc says antibiotics probably aren't going to help here. Tough it out. We got to stop this people shaking down their doctor for an antibiotic to give them a 5-star review.
Well, what's a parent to do when their kid seemingly has an infection?
So if the infection is clearly bacterial, or the kid is in a severe life-threatening course or trajectory towards disability, then sometimes you try anything because of the small chance it's bacterial. But the vast majority of kids that are coming in, and of people that are walking in with respiratory and other infections, are dealing with viral infections where an antibiotic doesn't do squat. And the doctors know it, and even sometimes people know, I've had this chronic dry cough, and the antibiotics aren't helping, but I'm just taking them anyway. I mean, people need to be judicious. And antibiotic-free foods are important because when we are giving antibiotics to animals, resistance is developing in those animals and it crosses over into humans. Most antibiotics manufactured in the U.S. antibiotics used are used in animals. And so we're breeding resistance. Now, some companies, Chipotle and a bunch of others, have said, we're going to stop, no more antibiotics. We're not worried about the antibiotic being in the food and affecting your health. We're worried about it breeding E. coli and other dangerous resistant bugs, because antibiotic-resistant bugs are the next pandemic. I mean, the WHO has made clear statements on this. It's already about 100,000 people in the United States that die from resistant bacteria where no antibiotic works because we've been using antibiotics too much. So this is something people need to be aware of. It's not a exponential pandemic like we saw with COVID. Antibiotic-resistant bacteria is going like this, and it's estimated to kill 10 million people by 2050, according to the WHO.
Scary.
Yeah. So people can do a lot to stop using antibiotics when you don't need. It's messing up the microbiome. It's probably contributing to chronic diseases. And when you make food choices, it's good to choose foods that were not raised with antibiotics.
That makes a lot of sense. There were recent headlines. This one that I'm going to read is from the Daily Mail, but this article permeated the internet and caused quite the stir in holistic health circles, autism communities, that a miracle trial, in quotes, claims severe autism can be reversed with symptoms reduced to an indistinguishable level when treated with regular interventions at a young age. So this was like a twin study. Are you familiar with this? The headlines that came out recently, there were two twins, and both of them had symptoms of severe autism, and they put one on a diet that excluded all ultra-processed foods, and it was a gluten-free diet. And allegedly this is a case report, so this is not a randomized controlled trial, but allegedly they saw a pretty profound, what they call reversal of symptoms on a whole foods, gluten-free diet. Can you speculate as to why they might have seen that?
Yeah, I didn't take a close look at that, but I did see that headline. And those are the things we need in the medical establishment, not to censor and black out and, this is, of course, it's obvious that this is incorrect. No, we need to be curious. And when we don't have any idea what's causing the rise in autism rates, we've got to say maybe there's a mechanism here by which the microbiome, which we know makes serotonin, is connected to mental health, maybe messing the microbiome in a generational way is also contributing. Now, I don't know if that association is there, but I can tell you this guy who is the world expert on the microbiome, Dr. Marty Blazer. We have the same first name, Marty. We call each other Dr. Marty. Hey, Dr. Marty. So he actually believes that the microbiome is associated with the autism incidents that we're seeing today. They didn't see it in the first round of data, but they did see it with learning disabilities. How on earth could changing the microbiome affect learning disabilities? Well, whatever that mechanism is, may also be connected to this rise in autism. And we also know people are more diagnosed. Sometimes we've witnessed in mental health the medicalization of ordinary life. Kids used to, when we were in school, we used to get nervous before an exam. Today they diagnose you. You have anxiety. It's like, no, I was nervous for an exam or going on a date or something. That's normal. That's normal childhood. And I think now we're doing this disservice where we're telling kids you have this, and that is converting American children to a generation of patients where there's no end in sight. And don't expect Pharma to say, oh, you know what, we're going to fund a study to look at other non-pharmacologic interventions. It's just not in their rubric.
I do get the sense that autism is on the rise, though, that prevalence is increasing. When I look at younger generations and peers of mine who are millennials who are now having children, it seems like everybody almost has, within their immediate family, somebody who's on the spectrum. So yeah, is there the microbiome? Obviously there are so many aspects of modern life that have shifted generationally, from generation to generation. But I do wonder what's at the root cause of it.
I wonder too. there are things in medicine where we see these sort of global societal trends, and the medical establishment oddly ignores them. For example, preterm labor, when a woman goes into labor before the baby is normally ready to be delivered, what we call preterm labor. That's always been a problem for centuries. That went way down during COVID. Why? Alzheimer's is, I think you have an interest in Alzheimer's. It's like 2/3 women. Why? There may be an association with the endocrine system. And when we've seen these studies now showing that women that start estrogen plus or minus progesterone right around the menopausal period have a up to 64% reduction in cognitive decline. One study found a 35% reduction in Alzheimer's. So there's a connection there, and it's amazing to me, Max, that we will spend billions of dollars on an Alzheimer's drug that barely works and has tons of complications, and we're not looking at the obvious. Here's a medication that's been around for, almost a century, and it's inexpensive, it's generic, and we're seeing these dramatic results. There's been studies looking at the Mediterranean diet and reducing the risk of Alzheimer's. Now, dietary studies are difficult because you don't know who's complying and there's other factors, but we should be curious about these connections. And with autism, I don't know what the signal in the data is, but I can tell you that just trying to come up with drugs for autism is a fool's errand.
Yeah, wow. It is so interesting, and you do get so much pushback when advocating for awareness around this topic. It feels at times like you're swimming upstream. I mean, I see it every day.
Yeah. I mean, I've kind of taken the position in my career, I don't care what people think of me, and I don't care if I get fired. We need people who are willing to speak up. We need scientists who are accomplished to just be able to say, I think there's an interesting connection there. Because right now there's like this curated, almost censored message, like everyone has to stay on message. Oh, there's somebody getting out of line, get back on the bandwagon. And it's not good for science. It's never been the way science has been conducted. Science is the study of challenging deeply held assumptions. So we can't say, we can't explore that because obviously that's absurd. No, it's the big ideas that have always disrupted our understanding. And we need those big ideas. Right now, when you become a doctor at a university, I'm at Johns Hopkins, but when you arrive and you get your desk and your phone and you got your list of patients, your first day at clinic, you're basically told you need to get an NIH grant in one of their little narrow silos of old belts and suspenders ideas. And you need to focus on one little narrow thing for incremental little discoveries, for little abstracts and little papers in specialty journals. What if you want to do cross-disciplinary research? What if you're interested in estrogen and Alzheimer's and autism and how the FDA approves drugs and how we spend too little time with patients and the important research on food as medicine that we need to usher in? You're basically told, stop, don't do that, get back in line. And now there's a movement in the medical profession to say, I don't care about NIH funding. There's private philanthropists that are funding research now because they recognize the government funding of research is about as flawed as the government funding of the Postal Service. And so good stuff is happening. We started a journal called the Journal of the Academy of Public Health. And so we have a new news feed where we critically analyze research that comes out from the bandwagon medical establishment. It's called Sensible Medicine. There's a bunch of us. And we need more Ben Franklin thinkers where, Ben Franklin was like working on ophthalmology and invented bifocals and lightning rods and discovered X, Y, and Z. We need these big thinkers. And right now, I think the movement is coming. People like yourself are asking the big questions in the medical profession. We got students coming through saying, I don't want to get on your hamster wheel, 10-minute visits. I want to spend time talking about treating high blood pressure by looking at sleep quality and stress management. I want to talk about food as medicine and magnesium and other supplements that may help. And so it's an exciting time in medicine, and that's why I wrote the book Blindspots.
Yeah, it's awesome. Do you think, though, that ultimately it's a doctor's job to prescribe nutrition plans? And I mean, it feels like, whenever I've had a medical emergency, I'm glad that I can go to a doctor and, I'm not necessarily going in that moment for a long-term diet and lifestyle plan.
Right.
I'm going for an intervention,
right.
Emergent care, for example.
Yeah.
So I just wonder if that's a reasonable ask, that doctors, come out of medical school training as experts in nutrition, particularly in light of what we know about nutrition science, that so often it's weak, captured by the food industry and the like.
Yeah, it's very corrupted. It's been traditionally a corrupted science. And so when people say, we need more nutrition courses, I've kind of been like, actually, maybe 0 is better than more, because...
That's how I'm starting to feel. I mean, it's like we don't need more studies to elucidate the benefits of fruits and vegetables, meat, eggs, fish, things like that.
It's amazing. Medicine is sort of rediscovering biblical principles, eating whole foods, eating clean meats, meditating. There's more mention of the word meditation in the New Testament than there is of prayer.
Wow.
Fasting. I mean, these are like ancient concepts, right? Medicine's like, hey, new research that meditation before going to bed helps. It's like, yeah, these are basic principles. So, yeah, I do think doctors have a duty. I understand the frustration. I think doctors come out of the system beat up, burn out, feeling like robots. They've been forced to memorize and regurgitate useless stuff on exams. And you were creating these people that are lacking self-awareness sometimes. They can't see the forest from the trees, but they can tell something's missing. And that's what folks right now within our medical profession are reconnecting with. Not, just, the traditional system. You come in, eat better, exercise more, avoid fat, whatever misinformation we would tell people. Come back in 6 months, here's some pills. And then they come back and we're like, you're a bad, non-compliant patient. And it's like, this system sucks. Like, patients hate it. We hate being in it. Like, what are we doing? Like, stop. This is obscene. And we've never really thought about the whole person. We've never thought about food. It's been off the radar. So it is the new revolution. It's one of the big frontiers in medicine right now. And the microbiome is part of that. There are endless probiotics. So many, you don't even know what to take. And the ones that tend to be the most popular are just the ones with the best marketing. But pretty soon, research is going to be able to elucidate which strains of bacteria are the ones that you want to get in there, more anti-inflammatory, produce, vitamins, GLP-1, whatever it is. And so we're starting to see research emerge on that. For now, I tell my residents and trainees and medical students, don't fight it. Encourage it. Be open and humble. Tell people, I don't know. That's often the right answer. And maybe they could benefit from trying some different probiotics or whatever it is they'd like to try. If it's not going to hurt them, what's the downside of just saying, I don't know, and do a little clinical trial and try to track whether or not it helps your abdominal pain or your energy level or whatever it is. And I think, I didn't write about COVID in the book Blindspots because it's too tribal and people are sick of it. But many times the right answer was, we don't know. And you did not see that level of humility. And beyond the rush of making a recommendation, once the data were very clear on so many topics, months, years into it, you didn't see really any acknowledgement that, we feel bad, we got it wrong, telling teachers in the summer of 2020 to wear goggles and gloves when they teach classes. Like, my feeling is NIH and these medical oligarchs that control the research enterprise, they can do any study in weeks to answer any big question. Why aren't they doing it? They'd rather opine on TV and, dilly-dally. And the problem is we have a lot of things we do in medicine that are just dogma. We have an epidemic of medical dogma. I mean, heck, we were putting heart stents in for a generation in hundreds of thousands of people with the thought that we're making them live longer. And when the Courage research trial came out, it showed no increase in survival with heart stents outside of an acute coronary syndrome. Now, it can reduce the anginal pain symptoms for people with angina, but all these people got heart stents thinking, I'm going to live longer now, I'm good to go. Zero survival benefit. So we need to do these studies early on. We've got this Bermuda Triangle. Just tell me if I'm talking too much, because I get so passionate about
No,
this.
I'm loving it, and I love the passion. Please keep
So there's this
continue.
thing called tongue tie surgery in newborns.
Right.
Kid gets born, and
My friends, their kid recently had that performed.
yes, it's soaring in the United States. It's increasingly being done. A newborn's born, and a doc or a dentist may do one of two things: selectively figure out who has a foreshortened tongue and then release the frenulum under the tongue, or routinely on every kid, they just believe that it's good for everybody, and they'll cut the frenulum under the tongue, sometimes the frenulum under the upper lip, which makes no sense to me, even sometimes the side of the tongue on both sides. Now, here's a practice which may be barbaric, based on dogma. There's no evidence. It's taking off like crazy. Maybe it should be done selectively, not on every kid. It desperately needs a randomized control trial to answer these questions, these claims that it helps with speech and sleep apnea later in childhood, or it could increase breastfeeding rates. Some kids breastfeed less because they're in pain from the procedure. So this desperately needs a randomized control trial, but it's in the Bermuda Triangle of research. Who's going to fund it? Pharma? No way. The American Academy of Pediatrics? Fat chance. NIH? No research center for it. It's not kidney, lung, heart. And so this is where we need to change the way that we do research in the United States. We've got to focus on health and what people actually are asking about, not just what the NIH guys tell us to study.
There was another study that came out recently that caught my eye, and I didn't read the study, but I read the press release accompanying the study. The study found that double mastectomy in patients with breast cancer didn't improve survival. Similar rates of death were reported in women with double and single mastectomies. Double mastectomy does prevent cancer in the unaffected breast, but it didn't. Here, let's see. I don't want to butcher this. I didn't read the full study.
Yeah.
But it found that getting a double mastectomy did not increase the likelihood a woman with cancer in one breast would survive. So
yeah. So double mastectomy is offered to people with the BRCA gene mutation, the genetic predisposition. What's happening in America right now is this incredible, weird thing. A woman will come in with a localized breast cancer in one breast, and either they'll say, just take off both breasts, and the doc should say, there's no increased risk in the other breast. I wouldn't recommend that, or I'm not going to do that. And sometimes it's the husband, in an old, there are these relationships where the male comes in and says, this is what you should be doing. And my wife, we still see that from time to time. But the consumer...
Why would that happen? The husband is advocating for the double mastectomy?
Yeah, I mean, think about not our network of friends where there's mutual respect in the relationship. Think about all of America. We take care of all of God's children. And there's some very dysfunctional relationships where the male dominates in that relationships and orders makes the decisions for the family. And sometimes that results in this consumerist demand being imposed. But when there's a patient that says, I want something done that has no medical benefit, we're now seeing this scary trend in medicine where the doctor will say, okay, well, that's what they wanted done. No, you do what's right. Okay, you don't have to do whatever they tell you to do. So that's a sad trend right now. So there are double mastectomies that are unnecessary. My research team comes up with appropriateness measures to profile doctors on the appropriateness of care they delivered, something we've never traditionally measured, but it's probably like the number one thing patients are interested in. And one of our measures is how often is a doctor doing a bilateral mastectomy versus a single mastectomy in patients without the BRCA gene mutation. We have a whole bunch of these measures. How often when somebody comes in with a groin hernia is the doctor fixing both sides? 10, 15, 20% could be reasonable, but not 80% or 100%. That tells you the doctor may be doing things just to bill, or it may not be up to speed on the. Most doctors do the right thing, or always try to. But when I spoke at a spine surgery conference, a big spine surgery conference, and the docs the night before at the dinner told me, Marty, your work on appropriateness needs to look at spine surgery. Up to half of spine surgery is unnecessary for back pain. I don't do neurosurgery. I do other types of surgery. But so I don't know if they're right. But if they're right, we have a crisis of inappropriate care. And the same is true of medications. You look at opioids, we're a little tiny peek into our broader overprescribing problem. That happened to be a highly addictive, lethal medication. But don't be fooled. There are many medications like that where the industry pushes it, we're giving it out liberally, there can be consumerist demand. So I wrote the book Blindspots to educate the public about our debates and internal struggles, things that we did talk about in medicine, because I think it's important for people to be informed. Now, there is a school in medicine that says, do not speak publicly about these problems. I mean, I've written now, this is my third book about the culture of medicine. And after each, people have basically suggested, and by and large, they're well received within the medical profession. But there's been this group that says you cannot let people onto the fact that we're having these internal debates. And you saw it during COVID. It's okay to talk about COVID. I don't like talking about COVID. And there's hardly any COVID in the book.
Needs to be talked about.
I think so. You're talking about the largest public health intervention in human history.
Yeah.
And people are like, whatever, we may have gotten it all wrong. Well, we have to evaluate how we did.
We got a lot wrong.
Got a lot wrong.
Yeah.
Ignoring natural immunity, cloth masks on toddlers, 5 vaccine doses on every 12-year-old girl in America that's totally healthy.
The blatant lies, if you get vaccinated, you're not going to spread COVID.
It's a lot of lying.
Yeah.
There's a lot of lying. And the fact that the entire COVID nightmare, the economy that's still in recovery, the poverty that was induced, the disproportionate impact on poor and minority communities, the 20 million people who died could have entirely been avoided. The entire pandemic was most likely avoidable had a bunch of scientists not been messing with a virus in a laboratory. And a small group of people get to decide what risks the world are going to take. And those people are not apologetic. They've dug in and they've basically said, you know what, and it should be done with the right technique and the right methods. No, it should never be done. Okay, these things should why are we messing with remote bat viruses from rural parts of the world flown into research centers in the NIH to show that you can infect a dog with it? What are we doing? What the hell are we doing? These people are playing around for personal, tiny little incremental gains, and the entire world bears the risk. And so we still need good boundaries on dangerous gain-of-function research. It's amazing people are pissed off at, somebody didn't wear a cloth mask during COVID, but they're not pissed off at the scientists that brewed this up in the lab.
Precisely. Yeah, it's incredibly frustrating. How can people listening to this, watching this, become better advocates for themselves and their loved ones when navigating the healthcare system?
So I encourage folks to be attracted to the doctors that demonstrate good humility and good listening skills. And they're out there. I mean, the rank and file doctor in America is not signed on and subscribing to everything that the oligarchs say. They're thinking independently. When I ask a doctor about the new best practices for childbirth, for example, delayed cord clamping, avoiding a C-section unless medically necessary, first-hour colostrum breastfeeding, maximizing skin-to-skin time, what we call kangaroo care, for hours. That's the best incubator for a baby, not separating babies from their moms at birth. There's something magical about the bonding. We're learning all these things about the best practices in childbirth. And when a doc just recites to me what their association says, like a catechism, I'm like, okay, you can think independently. It's Like there's all these recommendations now put out by centralized medicine where it's good to question them and it's good for a doctor to think independently. So when I meet a doc who says, there's a recommendation from the society that says this, but I tend to think this based on the mechanism, those are the doctors whose kids, the pediatricians whose patients did not develop peanut allergies because they said, yeah, there's a recommendation for total peanut abstinence in young kids. But I found, and based on other things I've read, that the early introduction of peanut butter in infancy, 4, 5 months of age, 6 months of age, as soon as a baby can start eating, mixed in with the breast milk or whatever the baby's eating, that prevents allergies. It's the old dirt theory. Now they're recommending introducing eggs and milk at that time. When I see a doctor think independently, say I don't know when they don't know, asking for help when they know that they're out of their area, those are the doctors you want to be attracted to. I tell my residents when they beat themselves up because I ask them a question, and we use the Socratic method of teaching, and I'll say, what are the indications for this? And they'll name 4 and forget the 5th one, and they'll be like, I'm an idiot. I need to know this. I'm like, look, what makes you a good doctor is not how much you've memorized and can regurgitate on a test. It's your humility, knowing your limits, knowing when to ask for help, and knowing when to look things up. And if we do that, we're going to learn more about the microbiome and childbirth and so many other things.
What would you say are the biggest and more pervasive nutrition myths that are keeping people sick today?
I think that we have a tendency in the hospital to just tell people, hold off on eating until we figure out what you have or figure out what you need to have done. In my own field, I'm a surgeon, and in gastrointestinal and surgical oncology, we have people told by tradition, dogma in the field, not to eat anything the night before, starting at midnight the night before surgery, to kind of like make sure your stomach's empty. Well, now we know you should be taking liquids up to 4 hours before the procedure, including taking a swig of Gatorade, not low sugar, but get the glucose in there. Your body's going to undergo one of the biggest physiologic stresses it's ever experienced in its life. And we want to keep your nutrition level. We want to start early feeding after surgery. So it's a whole new way of thinking. So I get asked all the time, what should we be doing in nutrition? What should we eat? And the reality is the research is in its infancy. I defer to a lot of guys that are deep into this space. But for the most part, I tell them, eat whole foods, better to eat things you can cook instead of buy, all pre-made, and just focus on these basic principles. We kind of know what's driving a lot of chronic disease. And the hard part of managing chronic disease is, as a doctor, it's not telling people what to do, it's helping them do it. If we just tell people, well, you're eating bad food, stop it, it's totally ineffective. If we can help people. And so in the old days, somebody would come in smoking and we would just tell everyone, stop it, you could die. And it was just this very crass, alienating relationship that sometimes created some distance with people who knew they weren't going to stop. They knew they were addicted. So now I do something different. I see that somebody smokes and I'll ask them, I see here that you've got smoking on your history. Is this something you're motivated to stop, or is this something you're fine doing and keep doing and you'd rather not get into it? And, I'd say most people say, I don't want to talk about it, I'm fine with it. But then you meet somebody who says, I just had a granddaughter and I would love to stop smoking. Can you help me? Well, we need to put all of our resources into that person, not just have a smoking cessation pamphlet for everyone we throw at them. And so the hard part about chronic disease is helping people. And you're seeing now these entrepreneurs develop apps and friends and text programs and ways to focus on, hey, we're going to help you with your diabetes management. We're going to help you pick food. We're going to help you we'll talk about so many different areas of health that we're an expert in. So they're called point solutions. Employers are getting them now for their employees as a benefit. It could be fertility-related point solutions or managing obesity. But it's one of the exciting areas in medicine right now. And the medical students we have at Hopkins, by the way, they don't want to practice like us. They don't want to just, and I'm not doing this anymore, but they just want to see patients 5 days a week and get some nice home in the suburbs. They don't want to do that.
Yeah.
Social justice is a generational value. They want to help people and they want to spend time and get deep into these topics. And so it's inspiring what's going on. Ultimately, I'm very optimistic because this new generation of docs, they're folks like yourself, like the others who are asking big questions, and I think good stuff is going to come out of it.
What are your thoughts on Ozempic? It's obviously trending.
Yeah.
I think in many ways it is a revolutionary drug, but there's obviously still long-term concern for different indications. What are your thoughts?
And it'll be interesting, these new generation GLP-1 drugs that act in combination with muscle receptor blockers to avoid the muscle wasting that we see with the GLP-1 drugs, because that's one of the big concerns. The muscle wasting is actually muscle mass is the number one predictor of longevity. And so when you're reducing your muscle mass as you reduce excess body fat, we're seeing one benefit, but we're also potentially accelerating frailty. And we don't know what that does to long-term survival. So
well, there's a way to mitigate that, the loss of lean mass, right? Resistance training, keeping your protein intake up.
Yeah, I mean, if you're a disciplined guy like yourself that's buff, I mean, going to the gym, sure, yeah, work out, eat a fair amount of protein so you can build your muscle mass and preserve it. So in the ideal person that's overweight, they're going to take that medication, work out like crazy, or keep some regular regimen and have enough protein intake. Because it reduces appetite, we almost see like a mini starvation state, which gets us excited in the short term. We see lower rates of diabetes and heart disease, dialysis, all kinds of stuff. And we high-five each other. But what are we doing long term? I think it's a little more unknown. So I mean, I have recommended it. It's ideal in our surgical setting because we need to get people thin for surgery to reduce surgical complications. I do worry about in children that we're just throwing Ozempic at the kids and not talking about school lunch programs. But it's interesting. I think we're going to learn a lot more once these more muscle-sparing GLP-1 drugs get approved, if they get approved.
Have you seen the latest South Park on Ozempic?
I heard about this.
It's really funny. It kind of nukes the fridge midway through the episode, but at the beginning there's a great line. Rich people get Ozempic. Poor people get body positivity.
Wow.
Yeah, it's crazy. I mean, because it is an expensive drug, I believe, for the obesity indication, is it not? Because it's typically covered. I could be wrong, but it's covered by insurance typically for type 2 diabetes. I don't necessarily know if that's the case for overweight and obesity, but
it's about $1,100 to $1,200 a year, and a year, or a month.
I think a month.
I'm sorry,
is what in the show, yeah. I mean, I don't know. I've never taken it, but it's about $1,200 a month.
Yeah, so it'll bankrupt Medicare if everybody decides to go eat potato chips all day and then just take these drugs for obesity. But you're right. It's typically getting covered now and it's only because insurers don't know what to do. They're panicking. Right? If you have a third of the population obese and maybe another third overweight, you put 2/3 of the population on this drug, you'll bankrupt every employer-sponsored health plan. You'll bankrupt Medicare overnight. So what they're doing is just throwing some roadblocks right now and saying, well, you have to have diabetes also.
Well, you'll bankrupt Medicare because of the cost of the drug, or because it would seem that the drug would, it's been shown, I think at this point already, to reduce risk of cardiovascular events.
Yeah, so does the ROI make up for it because of the reduced healthcare utilization? It's an unknown. But in the short term, I'll tell you, employers who manage their self-funded health plans at the employer groups where they cover the health benefits of their employees, they're panicking because in the first year or two, all they're seeing is the spend go up. And it's unknown. Is it going to reduce overall healthcare utilization or not? It's one of the studies we're doing on our research team. It'll be interesting to see. But there's something in public health called the moral hazard, which means if you develop a lawnmower that doesn't tip as easily, it can handle a much greater slope. You may not reduce lawnmower accidents at all because people may drive it right to the brink of where it tips. It's called the moral hazard. And so this has been an issue with a lot of things in healthcare. We can now do amazing liver transplants. We're now starting to look at taking pig livers or animals' livers or organs and transplanting them into humans. Well, what if it becomes so easy to do a liver transplant? Will people be concerned about liver failure going in, or they think, oh, I'll just get a transplant if that happens? I'm not saying one way or the other. I'm saying these are the moral hazards we think about. With Ozempic, we worry, are we going to see a long line at Krispy Kreme now that everyone can take Ozempic? And these are the moral hazards we don't think about. Pharma's not thinking about them for sure, but we need to think about them.
Yeah. Anything surprise you over the course of writing the book?
I learned a lot about the white coat era in medicine. I've got two types of patients. One that comes in with a lot of questions, sometimes with a little stack of Google printouts from their research. And the other that...
Do you generally encourage that a patient, quote unquote, doing their own research?
I do, although Google is proving to be very unreliable. The Google search is so curated now with a narrative. I mean, our study, we did the largest study on natural immunity during COVID. Couldn't find it. I mean, it was buried in there. It was published in our top journal, JAMA, published coming out of Johns Hopkins. Incredible study. It was number 2 most read study of the year out of JAMA. And Google buried it. LinkedIn censored it. It's just data. All we did was test the blood of people who had COVID to look at their antibody levels a year and a half, almost 2 years out, and see what those levels were. It was incredible. So I just a little commentary on Google. But I do encourage people to do research, get a second opinion, talk to other folks, watch what they can online. One group of people come in with, say, all this research they've done. They've got a lot of questions. Another type of patient will come in, and as soon as I start getting into the explanation of why I'm recommending something, they cut me off and say, Doc, just tell me what to do. I don't need to know. I'll do whatever you say. And I became curious about this unquestioned authority of the medical establishment. I mean, it's convenient for me, but is it good for the system? And at a time when we have an epidemic of overtreatment, inappropriate care, over-medicalization of ordinary life, the most medicalized generation in human history, and wide variations in practice patterns, I don't think it is healthy. But here's what I learned, is the modern-day white coat era of medicine began after World War II, roughly. It began when doctors had antibiotics now that were magical pills that could cure you. People died of infection, kids, women during labor and delivery would die from infections. You couldn't do surgery until antibiotics. It was discovered in 1922. Mass production began right around World War II. And so now doctors began to wear white coats. There was technology at the hospitals, iron lung machines, incubators for babies. People were dazzled by it. Hospitals were kind of known to be this incredible place of charity. They weren't price gouging and doing predatory billing like they are today. They were safe havens, regardless of your race or ethnicity or ability to pay. It was a beautiful thing. Before that, doctors weren't disrespected, but they were kind of seen like a barber. As a matter of fact, surgeons and barbers was a merged profession. They were called barber surgeons in the UK.
Wow.
And so they could pull teeth, and they basically could do two things. Do an amputation, and that was an art form, like who could do it the fastest. They had a lancet, which was a type of knife where they would cut you to let you bleed out, to get the bad humors out. And they had 1 or 2 medications that barely worked, like digoxin. But that was basically the only thing doctors could do. Put a bandage on you and pray and comfort you. So they weren't disrespected, but they were seen like you might see any other profession, a priest or a blacksmith or somebody. And then when the white coat era was ushered in by the discovery of penicillin and the fact that we could now prescribe a medication that could cure you, and only we could control the prescribing, we granted ourselves the solitary access to administer these medications. If you look today, we're doing a pretty bad job of the judicious prescribing of it. But people began to have an unquestioned authority of physicians. And in the field of OB, they began separating babies at birth and keeping them in the hospital, normal babies born at term, for 10 days, standard practice. And what were we doing? We were prying the babies and poking and studying them and starving them a little bit and feeding them the formula feed that, the industry told us was best for them. And it's like abusing these babies almost. And then by the 1970s, it drifted down to about 3 days. Normal baby was immediately separated on birth. Hey, or maybe here's a quick peek. Now we have to take the baby back to the nursery. I remember even as a student, like a baby was born, I cut this umbilical cord like it was my one task. Here's the scissors, cut. And I'm sitting there nervous, like, here's the cord, cut it, And it's like, what are we doing? There was blood pulsating to the baby. You should be cutting that cord at 2 minutes or something like that.
There's a benefit to delaying cord cutting.
Huge benefit. They're getting stem cells. They're getting warm blood. They're getting oxygen. They don't need to breathe for the first minute or so, even prematurely when they're getting this pulsating blood. And I remember they'd whisk the baby away, normal baby. And I'd say, where are we going? And they'd say, well, we got to go to the back table to rewarm the baby. I'm like, well, the baby was just getting a transfusion of warm blood into its circulatory system before you forced me to cut it the second it came out. And the mom, she had this like instinctive reflex to reach out for the baby when the baby was born, and they took the baby away. That's the best incubator. Have the mom hold the baby and skin to skin warm, like women have done for centuries. And then they would start probing the baby. And at the time, they were sticking a metal temperature probe in the butt. I'm like, is that a nice way to welcome a human into the world? And the baby's crying. I don't know what's going on. Baby's crying. I'm like, are they crying from the probe, or are they just crying because they're crying? Like, it didn't seem right. And slowly, over time, this white coat era of medicine began to take a look inward. And people in the field began to question dogma, like babies don't feel pain. So you could do procedures on them, even operate without anesthesia. This actually happened.
Wow.
And we have to restore that connection with the mother. There's something magical to the bonding. And in the book Blindspots, if any woman is about to deliver, I recommend reading this section on the white coat era of medicine and childbirth, because it's unbelievable how these best practices out there are still variably adopted in American medicine today. We're doing much better than we were, say, 10 years ago.
But it takes something like 17 years on average for what's discovered in science. Just a proportion, by the way, of what's discovered in science. I think it's like 20% to be integrated into day-to-day clinical practice, which is unacceptable. I mean, I guess there's probably a benefit to caution and, allowing time to sort of unfold. But I think so often we adopt procedures and even chemicals, food items, ultra-processed food ingredients, and we assume that we place the burden of proof on their safety on the consumer. Whereas it should be the other way around. The burden of proof should be on the medical establishment or the food industry or big chem. And it's inversed. More often than not, it's inversed, and I think that's a crime.
Well, first of all, I think the original idea behind doing these barbaric things like separating babies at birth was well intended because infant mortality rates were so high, and they thought, what can we do? Let's just start by separating the babies and studying them. But then the dogma takes on a life of its own, and we don't encourage questioning. Right now, we've got one private organization accrediting every medical school in the country. Should a small group of people like that have complete control over the education of America's doctors, where they force them to memorize the Krebs cycle and all this useless, I don't want to say useless information you don't have to know on the fly in the hospital? It's a joke. It's a joke. You have to know the molecular structure of certain bacteria. Why? We have Google now. There's phones. So this private company is controlling the accreditation of every medical school. So if a medical school dean says, hey, I want to teach communication skills, non-technical skills, self-awareness, empathy. I want to teach how you read somebody to figure out how to message to them what you'd like them to do. I want to teach humility. You can't because, well, you can, but the accrediting boards are going to be like, well, your students have to pass this test and the pass rates are going to define you. And the students are smart enough to know they got to pass those boards. And so everyone's focused on all these practice exam books and they know what's on the boards. The boards are not secret about what they test. You're going to have to memorize the urea cycle. And so we've got this backwards system. A bunch of us are trying to speak up about this so we can get back to a more sensible healthcare system. Matter of fact, we have a news feed called Sensible Medicine, where we talk about all these issues. We critique new studies that come out. I mean, we do so much stupid research. There was a study that came out funded by the NIH, NIAID, that looked at, do sandflies spread a bacteria called leishmaniasis between dogs? Well, they're like doing these cruel experiments on dogs. For what? Okay, sandflies do spread leishmaniasis. Great. I could have told you that. Like, who cares, right? And we're spending taxpayer dollars on this stuff. We're advancing careers in small incremental steps. But we need to take a step back and actually ask, what are people asking about? They're asking about what to eat, general body inflammation, how do I avoid cancer, how do I live healthy, how do I get my energy level up. My friend has abdominal pain chronically. What can be done for that? And those are the areas where we now have a trust crisis. People know our track record is not very good on some of those things. And so if people get shot or you have an injured, you fall, you break a bone, they want to go right to a doctor. They trust American hospitals. But you want to know what to eat, what to do for abdominal pain, my tummy hurts. People do not trust the modern medical establishment. And to bridge that trust, we have to talk about these issues, study them, and exercise some humility.
Yeah. And your background is cancers of the GI tract?
Yeah, I'm trained in gastrointestinal surgery and surgical oncology.
Super interesting. What are your thoughts on functional medicine? Does that does that growing field resonate with you? There's a lot of, I mean, we certainly are. I think, in general, I'm a fan of functional medicine, but it is, I believe, there is some controversy surrounding it in the field of evidence-based medicine.
Controversy is good, in my opinion. These are the debates we need to be having. Functional medicine, alternative medicine, holistic medicine. Sometimes we don't even know what we're referring to when we talk about this movement to challenge modern medicine's hubris and arrogance and traditions and dogma. But I like all of it. I think anything to ask big questions, to try new things, I think it's good. I think you look at some guys who've been pioneers in this field. They don't know sometimes what to be called. We don't foster that in medicine. The big pictures, the outside thinking, challenging deeply held assumptions. And this new group of folks, they're doing it, and there's market demand for it. So that's helping mature that field and making it a better, more mature science, it's burdened by a lack of good research dollars to support a lot of the stuff. But, a lot of crazy ideas started off as just ideas that ended up being, now medical truths.
Yeah.
So I like it. I think it's a good trend. I mean, gosh, the number of people have asked me, do you know a good functional medicine doctor in my area? And then, like in every area, there are good and bad clinicians, right? On traditional, functional, alternative, holistic, you name it. We call our research team the redesign of healthcare. It's not alternative medicine, but it includes that. It's not holistic, but it is holistic. It's not functional, but we support that effort. And there's no specialty, because when you show up at med school, they like give you the anatomy book and they're like, here are the organs, pick one. That's your for your career. You're like, what the heck's this? Maybe I'm interested in like helping people and the whole person and connecting with them and discovering new cool things in medicine. Maybe we need to spend more research dollars on environmental exposures that cause cancer, not just chemotherapy to treat cancer.
Yeah.
So that's a huge area right now. And we see these signals in the data. And by and large, they've been ignored. But now enough people are saying, hey, well, wait a minute. Why are we seeing high rates of cancer in this one high school, or goalies that have played on soccer fields made out of used tire rubber? I grew up in central Pennsylvania in a little town called Danville in the middle of nowhere. And that's like 1,000,000 miles away from here. It's like a whole different culture, but it's a coal mine region. And there's actually a coal mine fire that is still going on. It's been going on, 60, 70 years. They decided not to put it out because it's too dangerous.
Wow.
This thing's been burning. No one knows how it started. Someone thinks it was someone was burning trash.
A coal mine has been perpetually on fire for decades?
Yes, underneath an entire town.
Whoa.
I mean, miles and miles and miles. Because the area I come from in Pennsylvania, northeastern central Pennsylvania, they have something called anthracite coal, which burns really, really well, really clean. And so this coal mine has been burning. And I remember going to the mall as a kid, and my mom, would drive down this road near Catawissa was the town. And I'd be like, Mom, why is there smoke coming out of the ground? And she's like, oh, that's the Centralia mine fire. Okay, thanks. I mean, I assumed everyone grew up next to a mine fire. It's like that there was smoke coming out of the ground everywhere in the world. I didn't know the difference. I was a kid. My dad was
That's insane. And people want to change their diets for the climate, It's like that's just like a fire.
A fire.
Raging.
Fire raging. And
it's like when you hear, like certain pop stars, like their carbon footprint or something is like if you accounted for all of the agricultural, factory farming in the United States or something like that. It's like they output that on one, in 1 month of like their global tour,
Yeah, it's like stop watering your gardens in your home because we need to conserve water, even though 90% of the water is used by agricultural, industrial.
It's crazy.
So my dad was a cancer doctor, hematologist, leukemia, lymphoma, and he saw this incredible number of disproportionate cases of leukemias and lymphomas that were never normally seen in that region. And obviously, like I can't say for certain, but obviously there's probably a connection with the coal mines, maybe the coal mine fire. And you would think like the NIH would descend on this and like find an association and make recommendations. And it like still mostly is a blind spot, modern medicine, because the funding is just focusing on chemo drugs. But there's a lot of those things like that. And enough people now saying, hey, we're making like no progress with cancer. I mean, this is my field, cancer surgery. Like what progress have we made in pancreatic cancer over the last 50 years? Almost nothing. In terms of the population of people with it.
My mother passed from pancreatic cancer.
Sorry to hear that. It's brutal. It's a brutal disease. And you probably witnessed that. It's quick. And so there's almost like no good treatments that we have. The survival really has not changed much in 50 years. The surgery is pretty major, almost barbaric. And we need to try something new. Turns out the microbiome has been associated with increased rates of colon and rectal cancer. It's even been suggested to influence the rates of breast cancer. Maybe there's something going on in that chemistry lab of millions of different bacteria. Maybe it's driving body inflammation, which is a precursor of cancer. Body inflammation is highly actionable. There are low inflammatory foods. There are restaurants now that pride themselves in only selling low inflammatory foods. True Food Kitchen. I've seen stores in Austin, restaurants that do not have any seed oils. I mean, when 20% of our calories are coming from linoleic acid and a few molecules that do not naturally occur in nature, somebody's got to say, wait a minute, stop. We got to study these things. So this is the frontier right now. And we've got to push hard. The old guard medical establishment, you saw them in Clearview during COVID, they're all in their 70s and 80s there at the NIH, deciding what gets studied, what doesn't get studied. We've got to push them to say, here are new frontiers of medicine, desperate for good research, and we've got to support that research, fund it, and get going. Like, we cannot be doing research with the red tape that the NIH requires now. This is my little world of research, but people are hungry for answers. And if we don't give them good scientific answers, what's going to fill that void of scientific data are opinions and snake oil and remedies and all sorts of stuff. So we're at a real crossroads in medicine.
Can consumers help? Can advocacy on the part of the consumer, people from outside of the healthcare field, actually have an impact?
I think people are having an impact. I think people like yourself are pushing the field of medicine. I think people need to be putting out there big ideas. There's a bunch of podcasters like yourself that are putting out there big ideas, and now people are coming in to their doctors and asking about some of these things. There's Dogma that we've just accepted. Sensible Medicine is our news feed. We talk a lot about big issues in medicine now. I was one of the founders. I'm not writing for them much anymore because I was working on this book, Blindspots. Get the word out on health in Blindspots. There's a lot of really practical things that people should know now, from refined carbohydrates, ultra-processed foods, the myth of the low-fat diet reducing heart disease, allergy prevention, estrogen and postmenopausal women, even ovarian cancer, we're now learning, does not come from the ovary the vast majority of the times, and the most lethal type does not come from the ovary. So we took out millions of healthy ovaries, telling women we're doing it to prevent them from getting ovarian cancer. Turns out we're finding it doesn't come from we're targeting the wrong organ. It comes from the fallopian tube next to the ovary, and those cancer cells spill out and land on the ovary where they grow. And so we've now changed our recommendation just recently at Johns Hopkins, where we're saying, if you want to significantly reduce your 1 in 78 chance of developing ovarian cancer, then we will take out the fallopian tubes after you're finished having children. And if we're in there for another reason, that's when we offer it. Or if a woman comes in and says they want their tubes tied, we at Johns Hopkins now say, no, we don't do that anymore. We recommend removing the fallopian tubes to significantly reduce that risk of cancer. Now, we've had no progress in ovarian cancer, essentially. I'm overstating it a little bit, but basically we've gone zero and gone nowhere. Here is an opportunity to massively reduce the risk of ovarian cancer. Now, there's a couple more ongoing studies that are going to figure out how broadly we should issue this recommendation. But I wrote about all these things because I feel like there are things people need to know right now. And when people are informed and come in and see their doctor, they ask questions and it pushes the field. Just like restaurants, when they get the question, hey, is this food organic? Is this fish wild caught? Guess what? Enough people start asking, they're going to source their food differently.
I love that. Yeah, it's similar to the field of Alzheimer's disease. There's been virtually zero progress over the past 30 years, if not longer. And what you do get is essentially fraudulent, as we've seen with the fast track approval of these monoclonal antibodies that do nothing but essentially nothing but increase risk of brain swelling, brain bleeds, brain atrophy.
Adulaham.
Yeah.
And 19% risk of brain edema and fatal brain bleeds are noted. And then it was like it was 12. Well, this is the other drug that was approved. 12% increased. It how do you describe it? It increased the slowing of Alzheimer's by 12%. And if you look at the table in the New England Journal of Medicine, it was 0. It was non-significant for women, which is 2/3 of people with Alzheimer's. What are we doing? We just made thousands of people millionaires with $1 billion drug. Everyone's high-fiving each other. Media's peeing their pants. They're so excited about it. What are we doing? Estrogen reduces Alzheimer's by 35%. Diets have been suggested to reduce Alzheimer's risk. We barely even understand dementia because we're so busy working on drugs. We're not even looking at root causes. It's been suggested glucose metabolism, general body inflammation, a whole host of other things. We've tried a bunch of dumb ideas, like jellyfish products have been tried. It didn't work. So what are we doing? We keep going down this road of like the pharma is like telling us what we can and can't be interested in. So I encourage creativity, new ideas, big thinking, and we're going to get things wrong before we get it right, but that's how we get to the truth. In medicine right now, there's a bit of this sort of increased censorship, like, ooh, don't talk about that. Oh, you can't question the timing of the HPV vaccine in children. That's anti-vax. You're an anti-vaxxer. It's like this modern day McCarthyism. And it's not good for science.
Yeah, 100%. Are you optimistic about the future of medicine?
I am. I think enough bright kids are coming through that they don't want to have anything to do with this current broken system. I mean, think about it. Healthcare is the largest industry in the United States. It's over $4 trillion as an industry. It employs a lot of people, and it's funded on the paycheck deduction of American workers. When people get their paycheck, there's a deduction for their healthcare benefits for the 160-some million people with employer-sponsored healthcare. And then there's a Medicare excise tax. And so on the backs of everyday American workers, we're feeding this beast. And we can keep throwing good money after bad into this broken system, or we can stop and realize we have the most medicated generation in human history, and we've got to start thinking differently about treating health. The young people do not want to do these 10-minute visits. They want to think big. 50% of our medical students, roughly, don't want to practice full time. They want to master whatever specialty they're going into, and then they want to be an entrepreneur, think differently, redesign care, start a new type of clinic. We've seen the advent of subscription-based medical care now, where they can spend a ton of time and go deep. We've seen everything from concierge medicine to direct primary care, which has no added cost to the individual when the employer pays for it. Direct primary care is awesome. It's taken off like crazy. This is what the young folks want to do. It used to be that, I want to, be an orthopedic hip surgeon because they make more than an ophthalmologist and they make more than they're not thinking like that anymore. People are thinking impact, change, doing good. They're getting back to the roots of why they went into medicine. I think the biggest challenge we have in medicine is the critical appraisal of research. Right now, when a study comes out showing what somebody wants somebody likes, has results they want to see, oh, look at the scientific evidence. And when a study doesn't show what they like, don't talk about it, hush it, sideline it, maybe censor it. And the journals sometimes won't accept it. And that's a huge myopic tunnel that we're in. We need to promote the critical appraisal of research. Anybody can do it, but it's a skill set. It's something you get trained. There's classes, and so I think we need to focus on that. The book Blindspots is a bit of a guide to having impeccable objectivity in new information that you hear, not just in medicine, but in politics and business. People develop blind spots. People have strong preconceived ideas, and they tend to shut out. Good people can shut out new ideas. And so the formula basically boils down to this. Number one, you have to invite dissenting opinions. Hey, what could I be doing differently here? What could I be missing? Anyone have a different idea on a totally different way of thinking about this? Number two, create a culture of speaking up where no one gets intimidated or mocked or talked about behind their back for an idea that they propose that may end up being a bad idea. You've got to create a garden where people feel like they can try to plant a new seed. And number three is recognize that we all have biases and then suspend those biases as you hear new information. That was the charge of Claude Bernard, the father of modern medicine. He said, we all have biases. Let's admit it. It's okay. It's part of the human condition. But when you hear new information, be aware actively that you have those biases. Work to remove and suspend those biases as you hear the new information. Consider it objectively and then move on. But that is the duty of a scientist, he argued, and the duty of anyone to be objective. If you think about it, when Obama first ran for office, he was asked what his favorite book was. Do you remember that?
Mm-mm.
And he said over and over again, it was Team of Rivals, which was a book about Lincoln wanting to appoint members of his cabinet and bring in people who disagreed with him. And he did this all the time. Tell us why we should not have a civil war. Tell us why we should do this. Tell us why we shouldn't do that. And he invited this sort of active civil discourse. And that's what we need today. The echo chambers are polarizing us in directions that we don't even understand how we're being manipulated. With all the polarization around healthcare today, can we all agree that we need to be focusing on whole foods, general health, holistic care, researching topics we haven't been researching before, talking about environmental exposures, recognizing toxins, studying research different from the research we've been doing, starting fresh in these areas we've been making no progress, studying the microbiome, recognizing we've had these biases, suspend those biases, and bring in fresh new ideas. Instead of funding these old guard scientists, what if you took a genius guy like Dr. Vinay Prasad, Peter Attia, you name him, and said, here's $10 million, go research whatever you think is important. You can pivot 5 or 10 times, doesn't matter. We'll just be listening each year to see what you're up to. I bet you we'd have more major breakthroughs than the way we're recognizing research today.
Yeah, well, we all need to cultivate greater awareness of what it means to think critically, especially today. I know that that's something that we absolutely encourage on this podcast, and I'm super grateful that you're doing it with your book, Blindspots. Where can people pick it up? Where can they connect with you on? So, are you on social media?
Yeah, I'm on a bunch of things. Twitter, which can be a little bit of a nasty place sometimes, but I try to be kind to everybody. They're all God's children.
It's part of the experience. You just got to roll with the punches.
Part of the experience. I'm on LinkedIn, Instagram a little bit. I don't like what Instagram's doing to kids, but I do have an account there. And yeah, thanks for mentioning the book. I'm super excited about Blindspots. This is the product of a ton of research on the big blind spots of modern medicine. As I like to say, the big topics of medicine we're not talking about that we should be talking about. So I hope people enjoy it. It's available wherever books are sold.
Love it. Well, grateful to get to know you. Last question that gets asked to everybody on the show. What does it mean to you to live a genius life?
I love to be intellectually curious and just ask people about their stories. And I feel like you can learn something from everybody, even an enemy, even someone you disagree with. There's something you can learn from everybody. So to me, a lifelong learning journey, it feels great. I feel like I'm learning. And when I see a resident come out of our residency program at Johns Hopkins, say, this is how I'm going to do it, and this is, I've figured out my cadence, I worry a little bit when I see someone come out and say, how do you do it? And I've been doing it this way for a couple years, and I'm curious how you do it. Then you see this dialogue, and you feel like this person is going to transform into an amazing mind in the future. They're actively learning the whole time. Somebody told me, I was just at one of my co-residents. I was just at Pittsburgh watching this surgeon do this procedure and asked him why he does it this way. And we were in Washington, D.C. at the time, and I'm like, we're at Georgetown. I'm like, you went to Pittsburgh? How on earth do you just go watch one of these famous surgeons? He's like, I called him. I'm like, really? You can do that? He's like, yeah, I just called him and said, I'm a resident. Can I come and spend a day with you? And that guy did that 4 or 5 times. He ended up bringing me along with him once. And we're all just residents learning, but that guy has done this his entire life, reached out to people and just been bold enough to ask, hey, can I just come have coffee with you, have lunch with you, watch you for a day? And those are the people who are learning their entire lives, and they become geniuses. And so it's inspired me. I get people who call and say, hey, can I come watch you for a day or meet with you? People that are doing that a lot are learning. I remember this buddy of mine, he said something like, I did what he encouraged me to do. I went to Mayo Clinic, spent a day with a doctor. And I remember he took me out to dinner. I'm early in my training. And the world is a good place, and it rewards hard work, intellectual curiosity, and people that want to commit to a lifelong of learning.
Couldn't agree more. Thanks for coming in.
Max, great to be with you. Thanks so much for having me.
Of course. Check out Blindspots, guys. It is an incredibly important book. I love having this conversation. And obviously, we have a ton to learn and a ton, even more, to advocate for.
Hey, if you liked that video, you need to check out this one here, and I'll see you there.